Hi guys, today we'll discuss an important topic that is antepartum hemorrhage. This will be a long video because it covers both placenta previa as well as abruptio placenta. Now let's go into the definition. That is any bleeding which occurs into or from the genital tract beyond the period of viability, that is 28 weeks. What are the causes? Most important causes are placenta previa and abruptio placenta. Other causes are vasa previa, preterm labor, and rarely rupture uterus. So what is vasa previa? It is a velamentous insertion of the cord. Vessels are traversing over the internal os. As the internal os dilates, there will be rupture of membranes, as we all know. Along with the rupture of membrane, there will be rupture of fetal blood vessels along with cord rupture. So there is fetal blood loss. So in case of labor, blood mixed with mucus discharge is called as show. Most common cause of antepartum hemorrhage is abruptio placenta. Abruptio placenta, premature separation of normally situated placenta. Placenta separates before the delivery of fetus. Placenta is located in lower uterine segment, that is the placenta previa. Why bleeding is occurring in abruptio? In case of abruptio, due to the inciting factors like trauma, PIH, and inflammation, rupture of the blood vessels, that is from the spiral arteries in the decidua basalis, the placenta starts separating, so bleeding occurs. Due to collection of blood behind the placenta, there is increase in pressure in the intervillous space that will be releasing thromboplastin. It is a uterotonic agent, so definitely it will be initiating the process of labor and increased chances of DIC, that is disseminated intravascular coagulation. And if you see in the per-abdominal examination, the tone of the uterus will be obviously increasing, and uterus is tense, tender, and rigid. Release of thromboplastin and changes of DIC will be more if concealed variety of abruption is there. We'll see what is concealed variety later. Why bleeding occurs in placenta previa? In case of placenta previa, the placenta is located in the lower uterine segment. When the uterus contracts or the cervical changes occur, uh, when there is in case of placenta previa, there is no inciting factors like PIH or trauma. Pervaginal examination and intercourse are contraindicated in placenta previa, but TVS is not contraindicated. In fact, it's an investigation of choice. If we do PV or intercourse, there will be shearing forces that will be applied to the inelastic placental attachment site. So it will be opening the venous sinuses in the intervillous space. So it results in bleeding. Bleeding is not due to rupture of spiral arteries or detachment of placenta in case of abruptio. No retroplacental clot formation, no thromboplastin is released, so there are less chances of DIC, and uterus is soft, relaxed, and non-tender. There you saw tender and rigid. In, in case a female complains with bleeding at greater than 28 weeks, the first step you have to do is resuscitation. You have to introduce two large bore IV cannulas, number 14 and number 16, and take samples for ABO, RS typing, and complete blood count, bleeding time, clotting time, coagulation profile. Start ringer lactate IV infusion and oxygen by mask. Based on history and per abdominal examination, try to assess the whether it is placenta previa or abruptio placenta. How you will be finding in the per-abdominal examination? You have to see whether the uterus is tender, rigid, or soft or non-tender. After initial resuscitation, check vitals of the patient are stable or vitals are unstable. If the vitals are unstable or fetus is in distress, immediately do C-section. If the vitals are stable, next do TAS. In TAS, you have to screen whether in the placenta is in the lower uterine segment or there is retroplacental clot or placental thickening due to retroplacental clot or jello sinus present. If the placenta is in the lower segment, it is PP. Investigation of choice is TVS. If you see a retroplacental clot or jello sign, that is shimmering of placenta on movement of mother or the transducer, then it is abruptio placenta. The diagnosis of abruptio placenta is clinical. So abruptio placenta can't be ruled out with this TAS screening test. Note placenta previa or low-lying placenta can be detected on ultrasound accurately by 16 weeks of pregnancy, but diagnosis is not made at 16 weeks. 90% of cases, placenta located in lower uterine segment at trimester 1 or 2 undergoes placental migration, also called as trophotrophism, shift to the upper uterine segment in 90% of cases. The placental migration occurs due to differential growth of uterus. Lower uterine segment is formed from the isthmus of uterus. In trimester 1, lower uterine segment is 5 millimeters in size. In trimester 3, lower uterine segment is 5 centimeters in size. So from this to this, so relocation of placenta can occur away from the internal os. Always when placenta is located in lower uterine segment in T1 and T2, repeat ultrasound at 32 weeks. If placenta is in upper uterine segment, placenta previa is not present. If placenta is still in the lower uterine segment at 32 weeks, you have to repeat ultrasound at 36 weeks to confirm the diagnosis. We'll see placenta previa. What are the risk factors? Most important risk factor is previous history of placenta previa, the recurrence rate being 5%. What are the conditions causing placenta previa? If there is large placenta or factors which prevent migration and other factors. Other factors are increased maternal age, increased maternal parity, assisted reproductive technique, increased in maternal serum alpha fetoprotein. Factors which prevent migration are C-section scar, hysterotomy scar, and proportional to the number of C-sections performed, previous history of previa and previous C-section. If there is present, there is increased chances of placenta accreta spectrum. Large placenta, in case of twin pregnancy, placenta succenturiata, placenta bilobata, smoking, which leads to placental hypertrophy due to carbon monoxide hypoxemia. All pregnant female presently having placenta previa, you should have to rule out PAS, that is placenta accreta spectrum using Doppler studies. Classification of placenta previa. New classification, we divided it into only two, placenta previa and low-lying placenta. If the placenta covers internal os partially or completely, we call it as placenta previa. If the placenta reaches within the 2 centimeters of internal os but does not touch up to it, then it is low-lying placenta. In case of old classification, type 4 is complete placenta previa. Placenta covers internal os completely. In case of type 3, there is partial coverage of internal os. That we call it as partial placenta previa. In type 2, marginal. Placenta reaches up till the level of internal os. That is marginal. Type 1 is lateral. Placenta is within the 2 centimeters of internal os. Earlier, type 1 and type 2. Type 1, it can be anterior or posterior, or type 2 anterior. These three comes under minor category, that is minor degree. In case of type 2, if posterior presentation is present, it is a dangerous variety. In case of type 2 posterior, type 3 and type 4, major degree of placenta previa. On posterior varieties of placenta previa, stall-worthy sign will be present, and in case of type 1 and type 2 posterior varieties. Placenta previa clinical features, there is no pain. It is a painless abdominal bleeding. It is causeless. It will be recurrent. Initially, bleeding is less. There is a warning hemorrhage. Later on, followed by excessive bleeding. Bleeding is bright red in color. In general examination, the vitals will be normal. The BP of the patient will be normal. If in case of excessive loss, BP will be decreasing. In parabdominal examination, placenta doesn't separate. So, as the placenta is not separating, no thromboplastin will be raised, uterus will be soft, relaxed, and non-tender. Fetal heart rate is easily heard. Fetal parts are easily palpable. Fetal height of the uterus might be equal to the period of gestation or might be even less. because malpresentation or more in placenta previa. Transverse lies more than breech. In case of DIC is less common or not seen in placenta previa. Pervaginal examination is contraindicated as I said. Management of placenta previa. First, in case of placenta previa, is incidental finding in USG. At T2 scan, the patient has no bleeding. Patient B is patient of placenta previa presenting with bleeding. So in case of A, patient in T2 ultrasound is showing placenta in lower uterine segment. 90% of the cases, migration might occur. In case of B, signs on T2 ultrasound which tells that placenta will not migrate. What are the signs on the T2 ultrasound that the placenta will not be migrating? If that is posterior placental presentation or placenta covers greater than 25 millimeters of internal os. So, what are the advices you are giving to placenta on lower uterine segment in T2? You have to tell the patient to avoid lifting heavy weights, avoid medium to strenuous exercise, avoid long standing hours, avoid intercourse, immediately report if bleeding occurs, immediately report if uterine contraction occurs, advise a repeat ultrasound at T3. Further management in this female is TVS at 32 weeks. No PP or low lying PP in 32 weeks. If PP or low lying, you have to repeat it at 36 weeks. If no PP, you have to follow the routine antenatal care. So repeating at 36 weeks, if no PP or low lying PP, you have to follow routine antenatal care. If PP is confirmed, plan C-section between 36 to 37 weeks plus 6 days. If it is low lying placenta, discuss the risk and benefit for vaginal delivery. So if it is within 1 centimeter of the os, do C-section. If it is between 1 to 2 centimeters of internal os, better is going for C-section. But if the patient insists, try vaginal delivery. Remember, why is ultrasound important in patients of placenta previa? You have to do ultrasound in placenta previa to confirm the diagnosis, malpresentation if any present, to rule out placenta accreta spectrum. If C-section in patient of APH, you have to give general anesthesia to patients of DIC and give neuraxial anesthesia to patients of emergency C-section. In PP and the pregnancy and previous history of C-section, as I told, there is an increased risk of PAS. In all patients of PP, you have to do color Doppler to exclude PAS. In known case of PP and complaints of bleeding, you have to resuscitate the mother and assess for delivery. When you can do immediate delivery by C-section, that is active management of PP, and when you can do expectant management, that is prolonging her pregnancy, we'll see one by one. So when will you do active management of PP? If the patient is hemodynamically unstable, if there is fetal distress or CTG is non-reactive, if it is continuous or severe persistent bleeding or significant blood loss greater than 34 weeks, if the patient is in active labor, on ultrasound, there is gross congenital anomaly that is incompatible with life. If all these are not present, if the vitals are stable, fetal ultrasound and CTG is normal, no active bleeding, gestational age less than 34 weeks or greater than 34 weeks with no signs of blood loss, on ultrasound there is no gross congenital anomaly incompatible with life, then you can go with expectant management. The goal of the expectant management is to fetal lung maturity occurs provided not putting the risk of the mother's life. Expectant management. What is the regime called as Johnson and McAfee regime? You have to admit the patient, give corticosteroids for lung maturity. Preferably hemoglobin should be greater than 10 gram percentage. If gestational age is less than 34 weeks and contractions are present, give tocolytics. The given tocolytic is nifedipine for 48 hours. What are not given? Indomethacin and terbutaline are not given. If gestational age is less than 32 weeks, give magnesium sulfate for neuroprotection. In case of RH negative case, give anti-D, fetal monitoring, do NST weekly, biophysical score, ultrasound, no role of cervi- uh, cervical circulage. Termination at 36 weeks to 37 weeks plus 6 days. If there is no bleeding for 1 week, she understands the risk, has emergency transport, lives within 30 minutes of hospital, you can even discharge the patient. She has to follow up every 2 weeks till 36 weeks. Okay, we have completed with placenta previa. Now we will move on with abruptio placenta. What are the risk factors here? Previous history of abruption. So there is 15% of risk. Increase in maternal age, increase in maternal parity is controversial. Lupus anticoagulant and thrombophilia is controversial. Increased maternal serum alpha fetoprotein, increased in inhibin, increased in PAPI. Risk factors are cigarette smoking, cocaine abuses, folic acid deficiency, increased BP or thrombophilia, that is controversial. Trauma, polyhydramnios, twin, fibroid, premature rupture of membrane. Page classification. It is a clinical classification. It has grade 0, 1, 2, 3. Grade 0 is abruptio diagnosis made after delivery due to the presence of retroplacental clot. In case of grade 1 to 3, pain abdomen is present along with bleeding. In all 1 to 3, pain abdomen is present along with bleeding. In case of 1, fetal heart sound is normal. In case of 2, there is fetal distress. In case of 3, mother is in shock or fetal death has occurred with or without DIC. What are the types of abruptio placenta? The first variety is concealed. That is, the blood collects behind the placenta. There is increased chances of DIC and blood enters into the myometrium and the uterus appears bruised. We call it as covalar uterus or uterine apoplexy. There is revealed variety in which the bleeding might come out of the vagina. There might be a mixed variety combining the both. If there is covalar uterus, that is uterus appear bruised, it is not an indication for hysterectomy. There are increased chances of PPH and DIC. What are the clinical features? There in PP you saw the bleeding is painless, but here pain will be present. Inciting factors will be present. Trauma and PH will be present. Generally, bleeding is not recurrent, as in case of PP. Here, bleeding is not recurrent. No warning hemorrhages. In PP, we had warning hemorrhages. We'll just compare. Bleeding is dark red in color. Abruptio due to the release of thromboplastin, there might be high chances of preterm labor. In general examination, BP is high. There BP is normal or dropped, but the BP is high due to PAH here. Placental detachment occur, releasing thromboplastin. It is a uterotonic agent, so there is basal tone of uterus is increasing. So uterus will be tense, tender, and rigid. The fetal heart sound is not easily heard. As the uterus is tense and tender, fetal parts are not easily palpable. In concealed variety, the fetal height will be greater than period of gestation. DIC is common. Pervaginal examination should be done after ruling out PP. In patients of abruptio, PV in abruptio tells about cervical dilatation or labor has been started or not. History of trauma plus non-reassuring fetal heart sound could be sinusoidal heart rate or late deceleration or bradycardia. If this happens, always suspect abruptio placenta. In all cases of preterm labor, do perabdominal examination. If the tone is increased, suspect abruptio placenta. Indications for severity of abruptio placenta. Maternal sequelae, DIC, shock, transfusion, hysterectomy, renal failure, death. This is a sequelae. Maternal complication, non-reassuring fetal heart rate, fetal growth restriction, death, neonatal complication, IUGR, preterm labor, fetal death. What are the predictors of placental abruptio? Trauma and uterine contractions. What is chronic abruption? The placental abruption usually will be followed by the delivery. But if it is not followed by the delivery, it is known as chronic abruption. It may lead to oligohydramnios, fetal growth restriction, chaos. That is chronic abruption, oligohydramnios equally. What are the markers? That is maternal serum, alpha fetoprotein, and placental specific RNA. How will you manage abruptio? Vaginal bleeding and degree of separation do not correspond to each other. It is, in case of concealed variety, there will be less vaginal bleeding, and separation they will be not correlating. If placental separation is greater than 50%, fetal death and DIC chances are high. In case of 10 to 15 percentage of cases of abruptio, concealed hemorrhage, patients will be presenting with preterm labor. Resuscitation, moderate to severe bleeding, you have to do if the maternal vitals are unstable, or in case of DIC, acute kidney injury, non-reassuring fetal heart rate, do immediate C-section. In case of mild bleeding, give general anesthesia. Sorry. In case of mild bleeding, if the gestational age is greater than 34 weeks, you have to do maternal vitals are stable or the fetal heart rate is normal, you have to do vaginal delivery. If the gestational age is less than 34 weeks, do expected management like PP. Except for tocolytics is not preferred here. In case of trauma, APH and increased fetal-maternal hemorrhage, check for the Clauher Bedke test for dose of anti-D in case of RH negative. Fetal surveillance, do NST weekly, ultrasound and biophysical profile. What will be doing in the carry till 37 to 38 weeks and then induce labor. If recurrent bleeding occurs or oligohydramnios or fetal growth restriction, deliver as soon as possible. In case of DIC, you have to first correct the DIC and then do C-section. In case of coagulopathy or DIC, you have to give general anesthesia. DIC or consumptive coagulopathy. What are the causes? Obstetric causes: abruptio placenta, amniotic fluid embolism, sepsis, severe preeclampsia, eclampsia, HELP syndrome, acute fatty liver of pregnancy, and retained dead fetus, which is rare because we do not do expected management in retained dead fetus nowadays. How will you diagnose? These parameters are increased and platelet count, hemoglobin, and serum fibrinogen is decreased. It will be less than 150. Remember, fibrinogen is decreased and fibrin degradation products are increased. What is the management? You have to transfuse RBCs to fresh frozen plasmas to platelet at 1 to 1 to 1 ratio. What is the target? Hemoglobin should be greater than 7, fibrinogen should be greater than 300, platelet should be greater than 50,000, and APTT and PT should be less than 1.5 times the control. So, what are the bleeding in pregnancy? You have to think if in the question there is bleeding in pregnancy, you have to think of abortion, ectopic, molar pregnancy, antepartum hemorrhage, and postpartum hemorrhage. Thank you.